看不见的。那你负责这个？行行，没问题。尊敬的各位专家、各位教授，下午好。Ladies and gentlemen, good afternoon. You know that Carstens 是一个很大公司，在国外的话呢，就是神经内镜的，确实到美国、加拿大，去了很多国家，日本 ，Carstens 是主流的，确实做得很好，而且这次会议的话也帮助很多。现在呢就是邀请他们这个 marketing manager Snell 来讲一个关于这个 basic technique on care management of neuroendoscope equipment。这个设备是非常重要的，这个设备跟神经外科结合，可能造就了新一代的想法思路。Professor Oi already teach us many things about the equipment handling. I think this time from the Snell's that point of view, he will give you more space about not only doctors can use this. So, welcome. Yeah.
Good afternoon. I'd like to thank the organizing committee for giving us an opportunity to discuss on basic highlights, especially the care and maintenance of neuroendoscopic equipment. Well, there is an old proverb that prevention is better than cure. Well, we will all agree on this because of the fact that these days the repairs have started becoming more expensive than prevention. So keeping that new point of view, it is very vital for us to understand how equipment has to be maintained, especially the neuroendoscopic equipment, which is not very economical. As you treat patients with utmost care, we also sometimes refer our equipment as patients. And if you have the same philosophy, the way you treat patients, and you start treating the equipment, I am sure the return on investment would be very easy to maintain, and the longevity or the life of the equipment is also enhanced. Especially we have started moving from invasive to minimal invasive, and as a result of that there is a further miniaturization of instruments. So we want to achieve the basic objective of real minimal invasive surgery, means the endoscopes, the operating hand instruments are becoming smaller and smaller in diameter. That means more and more care is to be taken to really maintain them. It is very important to understand how to assemble, how to disassemble the various parts of the instruments, the endoscope, the sheaths, the grasping mechanisms, the bipolar forceps, etc., so that the longevity of the equipment is achieved. Let's start with the anatomy, as most of the lectures we've seen, they start with the anatomy of the cranial cavity, so I'll start with the anatomy of the endoscope. Well, it is basically rod lenses which are engraved in the tubular system, and between the two tubular system there are hair-like fiber bundles which are put here that helps in light transmission, which is connected from the light channel here, and it is delivered at the tip of the lens. These rod lenses are important, and special air gap spaces are maintained depending on the size of the endoscope, the length of the endoscope, and they are protected with metal spacers. That is important because in case there are small mechanical thrust or damages, so it prevents the endoscope. So basically the rod lenses are engaged into an inner tube, and then it is put into the outer tube, and in between the tube there are fiber bundles which are put here, and then they are all channelized here, and here is your fiber optic light cable which is attached. It is important to identify the angle of view of a particular scope, even if we cannot see, or sometimes in the OR the surgeon intentionally reduces the light so that there is no glare coming from the surrounding light on the video monitor, and in between you plan to change the scope from 0-degree optics to a 30-degree or a 45-degree. Then if the paramedical staff is not trained to really see the angle, sometimes they give you a wrong angle, and once it is attached to the scope, then again the trauma of taking it out and reconnecting it. The color codings are standardized. For a 0-degree optics, if you see, this is the light transmission bundle, it is green in color, so this is standardized, and for a 30-degree optics it is red in color, and for a 45-degree optics or a 12-degree optics, what Professor Shizoi showed yesterday, the OI Handy Pro, it is black in color, and a 70-degree optics is yellow in color. So when the scopes are lying on the sterile trolley, a surgeon or the paramedical staff, just by the color code, can identify what is the angle of the view and what surgeon has asked. So it saves a lot of time, and also the trauma to again, rechanging, reorganizing, reconnecting. This is how the angles of view are seen. Especially we say an endoscope is nothing but it is the eye of a surgeon in the cranial cavity. Depending on the lesion where you are seeing a retrocellular, supracellular, one can choose an angle scope and see a particular pathology around the corners. Now the endoscopes are available from various sizes. I mean, they start with 2mm optics, what we saw yesterday in the OI Handy Pro, and then they graduate up to 4mm optics. Again, various lengths are there depending on the length, the size of the optics, the sheets are designed. And it is very important to check in the endoscope that when a surgeon is trying to insert the grasping instrument or the biopsy forceps, these are called lure locks, and they are attached to the working channel, and in case the lure lock is not completely open and you try to insert a scissor, the scissor is sharp obviously from the frontal end, and there are chances of damaging. And these instruments are in the tune of 1mm, 1.3, 1.7. So prior to inserting, one must check the lure locks, they are open, so that the operating hand instruments are not damaged. Similarly for the bipolar, of course we know almost most of the ETVs that you do endoscopic third ventriculostomy, one may not require a bipolar in a standard procedure. But sometimes we have seen that suddenly there is a need of the bipolar. The bipolar over here is sometimes not connected with the lead. This is the bipolar lead. So sometimes it is not connected, or it is just put halfway through like this, and when an emergency arises and you need to coagulate, it is not working. Then you ask for another generator, and somehow there is not enough time to get rid of this bleeding. So it is very vital that before you enter the lateral ventricle or even make a burr hole, one must check the monopolar and the bipolar outside the cavity, probably on the skin or on some surface, that it is working, and you decide a medium power. And this has to be ensured so that these type of emergencies are met in case there is a requirement of a bipolar. Now, what is the ideal way of handling a scope? Sometimes the scopes are delivered and then we receive a call that we just purchased about 2 weeks or a week back and the scope is not working, although there is a warranty of 2 to 3 years on the scope. Now, why does that occur? What happens is sometimes the surgeon is trying to put the sheet and then the scope together, and or the paramedical staff has taken out the scope from the sheath and kept on the sterile trolley where there are more number of instruments. Tomorrow if you are doing spine, there could be heavy kerosene punches, and in a hurry to pick up one instrument, there is a mechanical dent which comes on the shaft of the endoscope. And we always say the strength of the chain is determined by its weakest link. So moment there is a mechanical thrust, the first rod length from the light transmission bundle is impacted, and as a result of that it breaks, and when you try to connect you do not get a vision, or you get a blurred vision which is not up to the mark, and scopes are expensive. So please ensure that endoscopes are never kept on the sterile trolley, or the paramedical staff handling it to you should be always engraved with the protection tube like this, and then put, even if you are sending it for disinfection in Sidex and these disinfectant solution, always a protection tube should be there, and it should be handled like this. This is the ideal healthy way of handling. The other thing we have seen sometimes is that if the sheath is there and you have to use an endoscope inside the sheath, and then you take a holder to engrave it in a hurry, sometimes you are fixing the sheath along with the holder and over tightening. What happens? A small dent comes in the shaft, and next time when you try to push the endoscope through this, it is not going. But you got to finish the procedure, you push more strength. Again, I told you earlier that the impact on the first rod length takes place and the scope breaks, or there is a mechanical thrust. So we have to ensure that the sheath is totally devoid from any mechanical dents, and one must inspect it. And the best way to align an endoscope would be not like this, because suppose this is already into the cranial cavity, you are already in the lateral ventricle, and you are aligning it like this. So what happens is, if the alignment is not straight, there could be a difference in the alignment and impacting the first rod length. So if you are aligning an endoscope with a sheath, it has to be in a horizontal fashion. Ensure the lever lock here is open, and then you push it like this. In case you feel there is a lot of resistance and you are not able to go, inspect for minor mechanical dents here, or send it to the service center, authorized service center, where the dents can be removed, and then you should push. Because at the end of the day, the scope is more expensive than the sheet. The other way is the light cable. There are two types of light cables available. The one is the fluid light cable, the other is the fiber optic light cable. The best light transmission, obviously where the light transmission loss is very minimal, would be a fluid light cable. But majority of the hospitals, they buy a fiber optic light cable. What do we mean by fiber optic light cable? There are hair-like bundles, hair-like fiber bundles, which are in the tune of 16,000 to 24,000, which are put inside this diameter of the cable. And as a result of constant twisting and bending, they are prone to mechanical damages. It is not possible in the service center to open the channels here and re-anastomose these fiber bundles. Once there is more twisting and turning, the fiber bundles will break, and you will start getting little lesser illumination compared to what it used to be some time back. So what would be the ideal way of handling a fiber optic light cable? They have a normal memory, like we have a normal hairstyle, they have a normal memory. One must engrave it into a bigger folds like this and let it have its normal memory, and then send for storage and sterilization. Not like this twisting and turning. The other illusion, what most of us we have, is let us buy a very thick light cable so that we will get more light. Nowadays people have shifted from halogen light source to xenon light source. Now let me give you a basic difference between halogen and a xenon. A halogen light source stands the maximum color temperature of 3400 Kelvin. A xenon light source is like a pure white light which is having a color temperature of beyond 6000 Kelvin. And nowadays most of the hospitals, they go for a xenon light source, and a surgeon might feel that let us have a thick light cable, we get more light. But what is the diameter of your endoscope? Your endoscope is 2 mm, 3 or 4 mm. So the xenon light source is sending a very high intensity light, the fiber bundles are getting heated up, when you are operating and holding the scope, especially in endonasal pituitary adenomas, you are holding the endoscope, you start feeling the heat, then it is overheating and it starts doing carbonization and damaging the fiber bundles, and as a result a pure optics is there and you don't get a good vision. Now when the endoscopes are bought, people usually bother to clean here at the ocular lens or at the tip lens. There are two adapters, adapter number 1, adapter number 2. Both the adapters should be opened and then you can use acetone and then take a gauze piece and clean. Why? Because if we do not open this, there is a constant heat light transmission taking place. It is heating up, sometimes blood debris comes, they get entangled here, and if you have not done cleaning over a long period of time, and when you use the optics, the light is coming at a high intensity, but the illumination or the brightness that you get is quite in the reduction form, or it is drastically reduced because carbonization has taken place. And as a result of overheating, again the damage to the fiber bundles which are ingrained here. So one must open both the adapters and then clean the endoscope. Now especially the 2mm optics which are there in the OE Handy Pro which we saw yesterday. If we have to handle or clean the optics, it is better that first a sheath should be there and then you support it like this, and then you should clean it in this fashion. Take these buds and with the acetone and clean it, because if you hold a 2mm optics and you take a cotton swab and then you are cleaning like this, again there is a mechanical thrust which is acting over here. So these dents which are caused here because of the wrong occupation of the holder, not at the place where it should be holding but on the sheath, can cause these dents which I already discussed, and as a result it is better to remove the dent or change the sheath rather than enforcing the endoscope inside the sheath which will break. Now some endoscopes have obturator with a hole. The hole is intentionally given for two purposes. It is compatible to your standard stereotaxy, plus when you enter lateral ventricle, the CSF starts flowing out, so you are sure that you are in the lateral ventricle, but one must ensure that the patency is maintained, it is open, and the brushes have to go inside. There are special set of brushes which goes inside these smaller obturators or the sheaths and clean it thoroughly. Now in case a damage happens for the optics, it should be sent to the authorized service center and not to any other place where they do not have the proper equipment to calibrate. And as a result, what happens, your image is not exactly in the center, it is away from the center and it is eccentrically loaded, and you will not able to do a better job as desired by you. Similarly, we have seen that when the fiber bundles of the flexible fiber scope, this is very important, sometimes we are using to do an aqueductoplasty or to do flexible endoscopy to see lesions around the corner. They are available in different diameters, 2.8, 3.7. Again, handling is important, because if you have gone through the sheath and you have bent it to view, while coming out you must operate the knob, make it straight and come out, because if it is bent, which accidentally is done, person forgets and then he is trying to pull it out, then there is a traumatization taking place at this bending area and the fibers are also damaged. So it is again important that here the luer lock has to be ensured it is open if you are putting a grasper, a biopsy or a coagulating forceps, and so that they are not damaged, because their operating channel out here is 1.2 millimeter. And when you use the fiber scope, you will find some black spots coming in. These black spots occur because you have damaged the fiber bundles. These are hair-like fiber bundles, and as I told you earlier, it's not possible for us to open and re-anastomose these fiber bundles. You have to change the whole fiber bundle cable assembly here. So similarly in the rigid rod lengths, also you can see when you connect the fiber optic bundle here, you can go on the sunlight, you clean the surface of the channel of the light source, light cable here, and clean it from here. In the sunlight, when you go, press from one side and see over here. So one side you press here and see here. If this surface is having some black spots like this, that means that percentage of the area is damaged. These fiber bundles have broken and it's damaged. And if you find too many coming here, it's better to change the light cable, which is more cheaper than changing the endoscope, because most of the bundles which are damaged will not be able to help you in transmitting the light to the optics, and as a result they will be overheated. Now, xenon light source is a powerful light source. The surgeon at times is changing from a diagnostic scope, which is like this, to a therapeutic endoscope, which is having some channels. Now, when you are changing this, the light is still at the full intensity. So there is a knob there. So somebody should be standing on the video tower or the video trolley, and whenever the surgeon is changing from a therapeutic endoscope to a diagnostic or vice versa, the light should be reduced here. One should not switch on and switch off the light source, every time you are changing the endoscope. Why? Because we are guaranteeing you for 500 hours. The life of the bulb or the expectancy is 500 hours, and if you do frequently switch on and switch off, then the life expectancy of the bulb also goes down. And there is a knob here. So moment you finish 450 hours, the red light starts glowing here, and a person may not recognize why the red light is glowing here. Earlier it was green. It is a signal to you that your time is getting up, 50 hours are left, so better you change a bulb. Otherwise, sometimes you continuously using it, it is still glowing red, and if you do not change the bulb, the power supply of the light source will vanish, and if that is hampered, then the cost of the repairs also goes very high. So it is better that when the bulb glows here, you change the light source and you reduce the light source and then change the optics, so that this light does not come to your eye, or the light cable is kept on the sterile trolley. It does not burn the sterile drapes or the skin of the patient. Now, endoscopic camera, as I said, is also referred as the electronic eye of the surgeon, gives you magnified image. Nowadays we are talking about high definition cameras. At times we buy expensive cameras, but if we do not buy an compatible monitor, there are times we have seen people buy 3-chip camera, but they are working with an ordinary television. No television can give you beyond 330 horizontal lines resolution. Your 3-chip camera gives you more than 750 horizontal lines resolution. So that means the final image that you get on the monitor is not the true endoscopic image or a 3-chip camera image what television is showing. So it is always better to buy a compatible, a high resolution monitor when you have a high definition camera. There are important parameters like gain, enhancement, shutter and white balance. The concept of white balance is important because if you do not do a proper white balance prior to the surgery and you start your procedure, and in between if you press the white balance button, it is going to sense the color, because camera does not understand color. It creates a white background in the memory of the camera so that your true natural tissue colors can be appreciated, and only then you get real colors. There are 2 buttons on the camera head. Now if by chance somebody has programmed the first button for white balancing and accidentally he presses when he is working in the endonasal cavity and there is slight blood there, so the camera will sense the red color of the blood as the white color, and you will find immediately distorted color. The blood would be looking something like tomato sauce and stuff like this. So it is very important that the right button is pressed for white balancing. So in case you feel there are too many people in the hospital operating the camera, it is better that you do the white balancing from this button. The second question comes that every time we change the angle of scope from 0 degree to 30 degree or 45 degree, do we need to do white balance? Well, the answer is definitely not. Now why do we need to do white balance? It is basically for the camera to sense the color temperature of the light source. If you are working with the same light source, for example xenon, and you change the angle of scope 0 to 30 to 45 to 70, whatever you feel like, you need not do a white balancing again, unless and until you change the light source from xenon to halogen or a metal halide. Only then only then you need to change. Well, Other part is the high frequency. Now there are bipolars which are available, and the bipolar has and the monopolar has insulations on engraved on that. And if we do not inspect it regularly and the insulations have given away, then there is a chances of damaging the electrodes, and also sometimes the accident can take place to the surgeon from the high frequency current. So it's very important to check the bipolar insulations are there or not. In case you find that there is a breakage there, it should be sent for the repairs. Induced chloride pitting takes place because of the very high hardness in the water. In some countries, the water may not be of the drinking quality coming from the tap, and they include the chloride induced pitting. It's like a communicable disease which is transferred from instrument to instrument, and those countries where the instruments are not autoclaved or probably put in the disinfectant solution or ETO sterilization, you find them getting transferred. So it's important that a good quality of water has to be used for thoroughly cleaning. Now when instruments come out like this on the trolley, and you are still busy closing the skull, and the scopes are sometimes kept with these some heavy instruments, and in case the sheath is not put, there could be a mechanical damage. There are different types of cleaners available. Ultrasonic cleaner could be one of the choices, but only thing, the endoscopes and the camera cable assembly, the camera head should not be treated in this, because there are specific air gap spaces which have been put in the various rod lenses, and these are working on very high mechanical vibrations, and there are chances in distorting these air gap spaces, and hence they are poor optics. So it is important to lubricate these areas where you have the laser welded rivet joints, because if you do not lubricate with the proper silicone, medical grade silicone oils, then you will find that biopsy is becoming stiffer, scissors are becoming stiffer day by day, and as a matter of chance that there could be breakage of the rivet joints and distorting the instrument. Well, sometimes we have a problem of space, and we put instrument or the unit over the unit. So on the top of the camera you put a light source, and then on that you have put a suction machine or endomat, stuff like this. Your equipment definitely needs ventilation. One should not put instrument on the instrument, because the units are also getting heated. They have to dissipate its heats to the surrounding and perform to the expectation level. And one must use the correct rating of the fuses. There could be a fuse going off, so it does not mean that if it is written 2 ampere, you put a 5 ampere or vice versa. A right fuse rating must be used whenever you change that. In drills also it is important to open and check in case there is a corrosive action taking place. It has to be changed, so it's better one should lubricate. Similarly, we have semi-flexible endoscope, the hand instrument, which goes through the side channel of the working endoscopes, and sometimes due to fast handling or mishandling, there could be breakage from here, and then the whole instrument is not functioning. This has to be inspected prior, so that we know that this instrument is has to be repaired or has to be changed. It should not happen that suddenly at the time of surgery we find that there is a flaw here. Well, since the time is left, I think I have covered most of the things, and these are some of the accessories which are required for the care and maintenance of the equipment. These are the special guns, and which can be engraved in your cleaning wash basin, and this is then put here under water jet. Different nozzles are there, so they can go in the corners of the instrument and you can flush, and the cleaning agents can be used. This is a special pen dropper with spring loaded, where the oil can be put. This is the Dura blade over here. It has a silver polish in this, so that the silver content of the instrument is retained, and you should use it once in a week, and it is anti-corrosive and corrosion will not take place. And these are the lubricants which are used on the stop box, so that the mechanism is smooth and it does not become hard, brittle and then break. So since the time is left, I think I have covered most of the thing, and I will just go nowadays. What we are actually coming out with the concept is the operating room of the future. We have observed that the dimensions of the operation theatre remain the same. Year by year, we add more and more equipment in the operation theatre because we are doing more complex and advanced surgeries, but the dimensions of the operation theatre remain the same. And when too many wires are hanging around, suddenly a camera is not working on the light, so it becomes difficult and takes a lot of time to find where the problem lies. So now the concept is of making an operating room in this, where you have ceiling suspended boom arms and everything is on the ceiling suspended arms with the trolley, and you have enough working space down, and this also fastens your procedure and reduces your various troubleshooting. Well, with this I am through. Thank you very much for your patience listening, and if you have any questions, you can check me on the mail or Ms. Jackie Lu, who is in charge here for China, based in Beijing, and we have office here in Shanghai, also in Beijing, as well as repair centers. And with this, I'll say the future has tradition and tradition has future. Thank you very much for your patience listening.
各位可以带着我马上演讲台了。